Perinatal mood and anxiety disorders in California's low-income Medi-Cal population, a social justice issue. Perinatal mood and anxiety disorders, or PMAD, can occur in up to 20% of women during the perinatal period and are among the leading cause of complications associated with childbearing. PMAD is a spectrum of disorders that can present any time during pregnancy and up to 1 year after delivery. It includes what we commonly know to be postpartum depression, anxiety, obsessive-compulsive disorder, bipolar disorder, and rarely postpartum psychosis. Left untreated, PMAD can have far-reaching negative effects on the mother, newborn child, family unit, and society at large. Health inequities spurred by structural deficiencies in California's Medicaid program, known as Medi-Cal, exacerbate barriers to evidence-based care for PMAD in low-income women. According to Varcoe, Brown, and Sunder, equity suggests that all people should have the same access to health and health care. This isn't the case in California's poor perinatal women. In fact, the public safety net that is set up to provide their health care is failing to provide them with access to validated PMAD screening, treatment, and behavioral and social support. Currently, although there is guidance to screen for PMAD in Medi-Cal perinatal women, statewide implementation of this policy is not uniformly carried out, nor is screening being done using a validated tool. Furthermore, if screening is performed, there are often large gaps in care related to treatment either with medications or behavioral services and/or social support. This inefficient system of care is widening the gap of this already marginalized group of women and places them in a space of being further entrenched in inequity. This is no longer just a health disparity. This is an issue of social injustice, and something needs to be done to ensure that these structural inequities are rectified. As many as 1 in 5 women in the United States will experience a mental health disorder following childbirth. Children of mothers with depression are more likely to use healthcare services than children of healthy mothers. Depressed women have an approximately 90% higher healthcare expenditure than their unaffected counterparts, and the annual overall economic burden to the United States for untreated PMAD-related issues is estimated at over $5.7 billion. Children born to mothers with PMAD are at increased risk for behavioral disorders, manifested in maladjustment to social, intimate, and academic roles, as well as at higher risk for depression in the future. There are many factors associated with a greater likelihood of PMAD, including life stress, lack of social support, lower education levels, lower income, and being a Medicaid insurance holder. Research indicates that women with socioeconomic risk factors are 11 times more likely to develop PMAD. Low socioeconomic status is one of the greatest predictors of maternal mental health disorders in the United States. To further worsen the issue, in the state of California, Medi-Cal insurance holders are less likely to follow through with postpartum care visits. California has one of the highest rates of poverty in the country. In 2012, there were more than 500,000 live births. 46.4% of them were funded by Medi-Cal. Data from the California Department of Public Health's Maternal and Infant Health Assessment is in line with national data surrounding PMAD, and estimates that approximately 1 in 5 California women experience depressive symptoms during the perinatal period. Now let's look at a potential solution that can help to improve these staggering statistics. Mandatory statewide legislation that requires all perinatal healthcare providers to screen, diagnose, treat, and refer if necessary women in the perinatal period at least once during pregnancy and once in the postpartum period should be adopted throughout California. These interventions should be based on evidence and include best practice, such as the use of a validated screening tool. A policy which mandates screening, diagnosis, treatment, and appropriate and timely referral would encourage California's Medi-Cal program to come up with ways to incorporate these mandates into their practice. We know that the current Medi-Cal policies include guidance on at least screening women for PMAD. However, this guidance is not being actualized in practice, and the vulnerable women who rely on Medi-Cal for their health needs are further marginalized from receiving evidence-based PMAD treatment. A statewide mandate would help all women throughout California and ultimately end up benefiting Medi-Cal recipients as well. With a requirement for all providers and payer sources to adopt evidence-based PMAD care, it is hoped that more mental health professionals will be available to service the community at large. In turn, it is also hoped that these providers can be encouraged to contract with Medi-Cal systems as well. Further policy issues might even include incentivizing reimbursement for Medi-Cal behavioral health providers. Overwhelming support exists for the use of validated tools to screen for PMAD, as well as to treat and refer women with PMAD symptoms in the perinatal period. In fact, in a recent systematic review on depression screening in adults, including pregnant and postpartum women, screening in concert with treatment and follow-up was shown to accurately identify mothers with PMAD, as well as improve health outcomes in this population. Despite the lack of robust evidence in support of mandatory screening, we do know that states with like mandates, such as Illinois, have noticed increases in screening rates, which ultimately leads to detection and the opportunity for healthcare providers to treat an otherwise invisible disorder. The multi-level model of health supports the theoretical framework for this solution. As this social policy is adopted, the implementation and effects will be manifested throughout the remaining underlying shells and intersect with almost every level of the model. This solution, which occupies the model's highest level, will, in effect, have the ability to positively affect the mother and infant's lives at the foundational level, which ultimately benefits the population at large. So who are the players in all of this, and who bears the cost of postpartum depression? Well, we know that low-income Medicaid recipients are at higher risk of developing PMAD. Without receiving adequate treatment, they are at greater risk of suicide and suffering chronic depression throughout life. Untreated PMAD has been associated with serious consequences of impaired mother-infant bonding. This can cause long-term effects on emotional behavior and cognitive skills for children. Research has shown that children of mothers depressed during infancy show poor self-regulation, aggression, poor peer relationships, and difficulty in school. These children are the future of America. We are leaving them with mothers who are chronically depressed, committing suicide, and setting them up for a lifelong struggle with emotional and cognitive issues. So, as you can see, the families, primarily the children, are the ones that are bearing the cost of untreated postpartum depression. The current recommended treatment for PMAD, based on national guidelines, is the use of behavioral therapy either alone or in conjunction with medical therapy, such as antidepressants. When looking at the big picture, the pharmaceutical companies and mental health counselors and providers gain from PMAD and its current treatment recommendations. Now, who benefits from the solution and who bears the cost? Well, mothers, their children, the healthcare system, and society at large would benefit from the solution. By making screening, treatment, and referral mandatory, we are addressing PMAD in its early stages and getting women the help that they need to prevent long-term complications for themselves and their children. Mandatory screening would create a need for more mental health providers, which would encourage job growth in this area, as well as offer a continuum of care to affected patients. Because the solution would be a statewide mandate for all perinatal providers and both private and public payer sources would be affected, taxpayers and individual private insurance holders would bear the cost of the solution. To further expound on the costs and benefits the solution would incur, the cost of policy implementation would mostly be shouldered by payer sources, both private and state-funded. Currently, mental health treatment is mandated by the Affordable Care Act, and screening, treatment, and behavioral health coverage is a benefit under most insurance plans, including Medi-Cal. The increase in cost from this policy would come from the utilization of these benefits, and insurance companies will need to adjust their practices and budgets to accommodate new utilization of services encouraged by the policy. Untreated PMAD and the detriments it has to not only the mother, her infant, family, and the society at large would be mitigated through this policy, and the benefactor of the policy is ultimately the entire community. As we've also discussed, a statewide policy based on evidence-based best practices to mandate screening, treatment, and appropriate referral for all women in the perinatal period is needed to decrease PMAD throughout California. A universal screening and treatment law would not only benefit low-income Medi-Cal recipients, but every woman throughout the state. By mandating screening and treatment at the state level, the state's Medi-Cal program will be obligated to comply with lawful regulations and implement strategies throughout its system to ensure that perinatal Medi-Cal insurance holders receive evidence-based PMAD care based on best practice guidelines. Using the Milstead process, we can see how to approach developing and implementing this policy. With regard to agenda setting, the presence of all maternal mental health players in California and local coalition representatives from the California Task Force on the Status of Maternal Mental Health should convene to discuss the evidence-based PMAD recommendations released by national organizations. The goal should be putting pressure on government officials to draft the suggested PMAD policy. Inclusion of state legislators with a history of previous maternal mental health legislation should also be sought, and buy-in should be elicited from Medi-Cal and other private insurance administrators to support effective PMAD care policies statewide. The case should be made to insurers that choosing not to screen, treat, and refer ultimately costs our nation $5.7 billion annually, and sound evidence points to the benefit of mitigating PMAD through evidence-based practices and policies. We are requesting the government's response to our proposed policy to expedite the current need for mandated screening, treatment, and referral to decrease the prevalence of PMAD and its associated implications. State legislators should draft a bill requiring all perinatal providers to screen, treat, and refer for PMAD in their perinatal patients. As mentioned previously, the bill should mandate screening with appropriate follow-up at least once during pregnancy and once during the postpartum period. Direction in the policy regarding intervals should be worded to reflect frequency based on current best practice, evidence-based guidelines. Although no policy currently exists, if a bill passes to reflect the current suggestions, the state should release information regarding the new policy on all of its health-related websites, as well as in written literature. The effective date should be released to all providers throughout the state, including those who accept both private and Medi-Cal payments, as well as all of the state's private and Medi-Cal managed care insurance systems. Ideally, a program evaluation to determine if mandatory screening, treatment, and referral had the desired effects should be extended to all first-line maternal child provider types and payer sources. Both process and outcome measures should be included. Process measures should include if and when PMAD screenings occurred in the perinatal setting, if medical treatment was initiated, and if women were referred to outside behavioral specialists and/or supportive services. Outcome measures should include data on a decrease or resolve in PMAD symptoms. A review of both Medi-Cal and private insurance encounter data would allow for evaluation of screening, treatment, and/or referral incidents. Outcome measures could be evaluated through a reassessment of the mother utilizing the same validated screening tool at designated follow-up postpartum visits. An additional statewide database to capture findings from all providers and payer sources would help to determine the Act's effectiveness and guide future policy regarding perinatal mental health in California. We hope this presentation has increased your knowledge of PMAD, its effects on women and their families, as well as the importance of routine screening, treatment, and appropriate referral. It is important to take steps to improve legislation to mandate PMAD screening, treatment, and referral in order to improve health outcomes for women, families, and communities.